Okay, thank you much. I'm Gao Mingxin from the First World of Cardiac Surgery Center at Anzhen Hospital. Today, I'm here to present on behalf of my leader, Professor Li Haiyang, and give me this chance to share the new something new in 2024 ESC guidelines. Yeah, there is some different progress in the 2024 ESC guidelines compared to the 2018 guidelines. And for CCS patient with left ventricular ejection fraction below 35%, if the PCI can provide complete revascularization and to cabbage, the PCI was recommended by the 2018 guidelines. However, in newest guidelines, it pay more attention to the surgical risk and operability. For the patient with high surgical risk and not operable, PCI would also be recommended by the new guidelines, but the evidence level upgrade from C to B. And for patients with left main disease, no matter the patient with low syntax score or the intermediate syntax score, the PCI was also recommended by the old guidelines. But in the 2024 guidelines, if the PCI can provide equivalent completeness of vascularization, the PCI was recommended by the new guidelines. And for patients with left main with multivessel disease, if the patient with high syntax score beyond 33, the PCI was not recommended by the old guidelines. But in newest guidelines, if the patient with the high surgical score, PCI would be commended by the new guidelines, and the evidence level upgrade from 3 to 2B. And it's amazing that PCI will, as I know, and what we do in Anzhen Hospital, if the patient with high syntax score, we always provide the patient to receive the cabbage. And if the patient with high surgical skill, we also concern about the hybrid coronary by revascularization. It's different from the new guidelines recommendation. And for patients with more multivessel disease and diabetes, for the patient with low syntax score below 22, PCI was recommended. And if the patient with the intermediate or high syntax score, the PCI was harmful for people and not recommended by the old guidelines. But in 2024 guidelines, for the patient with very high surgical risk, PCI also recommended by the new guidelines. And for patients with a single or double vessel disease involving proximal LAD, both cabbage and PCI was recommended by the old guidelines. And if the patient was not amenable to PCI and insufficient response to guideline-directed medical therapy, the cabbage is recommended. The recommendation strength was similar to the old line. For the patient with single or double vessel disease not involving proximal LAD, the PCI and the cabbage were also recommended by the old line, but the evidence level was only C. And in the new guidelines, if the patient symptomatic CCS patient with single or double vessel disease not involving proximal LAD, and the insufficient response to guideline-directed medical therapy, PCI was also recommended by the new guidelines, and the evidence level upgrade from C to B. Now I will introduce some recommendation for the specific coronary artery stenosis. For the patient with left main disease, if the patient suffered the low surgery risk, the CABG was recommended by the new guidelines to improve survival and reduce the risk of spontaneous myocardial infarction and repeat revascularization. But if the PCI can provide the equivalent completeness of revascularization to CABG, to CABG, PCI is also recommended no matter the syntax score is low or intermediate. And for patients with left main with multivessel disease, if the patient suffered a low surgical risk with suitable anatomy, CABG was recommended. But if the patient with a high surgical risk, PCI was recommended. For multivessel disease and diabetes, the CABG is recommended as our clinical tool. And for the patient, if the patient have the high surgical risk, PCI was also recommended. And for the patient with three vessel disease without diabetes, if the patient with significant three vessel disease, preserved left ventricular ejection, and no diabetes and insufficient response to guideline-directed medical therapy, CABG was also recommended by the new guidelines. If the patient with low to intermediate anatomic complex, the PCI can provide the similar equivalent completeness of revascularization. PCI also is recommended to the three vessel disease without diabetes, and the evidence level is strong. And the recommendation of the single or double vessel disease have been said before. So that's the 2024 ESC guidelines for CABG. CABG is recommended as the preferred revascularization modality for low surgical risk CCS patients with significant left main stenosis because of lower risk of spontaneous myocardial infarction and revascularization significantly lower than PCI. In heart failure patients with ejection fraction below 35% and suspected of obstructive coronary artery disease, coronary angiography is recommended in order to improve prognosis by CABG, taking into account the risk to benefit ratio of the procedure. In patients with CCIS who have significant single or double vessel disease involving the proximal LAD and with insufficient response to guideline-directed medical therapy, CABG or PCI is recommended over medical therapy alone to improve symptoms and outcomes. In patients with CCIS who have complex significant single or double vessel disease involving the proximal LAD and who are amenable for PCI and who have insufficient response to guideline-directed medical therapy, CABG is recommended over PCI to improve symptoms and reduce the rate of revascularization. In patients with symptomatic CCIS, CABG may be considered for symptomatic improvement. Okay, after CABG surgery, if the patient suffer the CABG failure or the graft occlusion, the new guidelines also provide some correspondingly treatment to these people. If the lemur was not used previously, lemur the guideline recommend using lemur to redo the CABG, and if the lemur graft occlusion and the guidelines recommend us to redo CABG, and if the PCI has chosen to be the revascularization mode for this patient, the guidelines suggest that we treat the native coronary artery and bypass graft. So next, I will introduce some post-CABG medical therapy. If the patient without bleeding risk, the aspirin 75 to 100 milligram should be taken as soon as possible. And dual antiplatelet therapy has been demonstrated improve the graft patency. The dual antiplatelet therapy, including the aspirin and the ticagrelor, shows the effectiveness. So the effectiveness improve the graft occlusion compared to the aspirin alone. And for the patient who needs long-term anticoagulants such as the atrial fibrillation, the VKA, and direct anticoagulants should be was recommended in the new guidelines. And for the lipid-lowering drugs, the goal of our DLC should be controlled 1.4 or reduced from 50% from a baseline. If the LDLC cannot reach the standard by the statins, the recommendation significant sequence lipid lowering drugs were the enzalutamide and bempedoic acid and PCSK9 inhibitors. And for patients with recurrent thrombotic events, the goal of LDLC should be controlled below 1.11. And for patients with hypertension or the heart failure, the ACEI and ARB are recommended after the CABG. And for patients with type 2 diabetes, SGLT2 inhibitors and GLP-1 receptor agonist should be taken to prevent the cardiac event independent of glucose lowering medication. And for anti-inflammatory drug, a new drug called concizin. If the low dose concizin should be considered to reduce the myocardial infarction, stroke, and the need for revascularization. And these drugs would be approved by the FDA in 2024, and the effect whether it can work for the patient after CABG is not clear.